Can you hear me?
Yes.
काम नहीं ठीक कर कोई बात नहीं शेयर हो रहा है
Good evening, Dr. Shabda.
Good evening. Good evening.
Good
So
evening to everybody.
Good evening, sir.
Dr. Joy. Dr. Shankaracharya. Good evening. Welcome.
Thank you.
Yes. And Dr. Karthik Clash also welcome.
Dr. Joy Shetty is also there.
Welcome to him also. Thank you very much.
Tyagi has also joined, Chabra.
Hi. Yes, sir.
Dr. Amman
We start on time, Dr. Tandon.
Sir, Dr. Sibal has joined, so just 1 or 2 minutes are left.
Right.
Dr. Chabra, you may start, please.
Right. Good evening, everyone. Today is the first webinar of GAPIO ASSI collaboration, and I have the privilege of being the moderator for this session today. The topic of the webinar today is myths and facts of back pain, a very important topic which is relevant to a large number of physicians and surgeons alike across the globe. I would want to start by welcoming Dr. Anupam Sibal, the president of GAPIO. I'd also want to welcome Dr. Shankaracharya, president of Association of Spine Surgeons of India, Dr. A.K. Tandon, honorary advisor of GAPIO, the chairperson of the session, Dr. Sudhir Kumar Tyagi, a colleague of ours, as well as other colleagues who are panelists for the session from Association of Spine Surgeons of India, Dr. Ajoy Prasad Shetty and Dr. Karthik Kailash. And of course, a very warm welcome to all the participants who are participating for this first initiative of the GAPIO ASSI collaboration. A word about GAPIO. In fact, GAPIO stands for Global Association of Physicians of Indian Origin. It is created to empower physicians of Indian origin to achieve highest professional standards. And the vision of GAPIO is to improve health worldwide. Similarly, a brief introduction about the Association of Spine Surgeons of India, or ASSI. The association was built to increase knowledge about management of spinal ailments in India. Under its umbrella falls training of budding spine surgeons, experience sharing, and participation with different countries of the world, showcasing the current scenario in India. And that's what we are doing today. The webinar is, as I mentioned, the first in the part of an international webinar series, which is being conducted by GAPIO in association with ASSI. And today, as we mentioned, we'll be discussing the common myths and the facts of back pain. This is a joint effort between the physicians and the spine surgeons, which will help in clarifying the common myths with the vast experience of the stalwarts. With this joint effort, the benefit will be to the patients, as back pain is the most common ailment after common cold, as many of us would know. By the end of the session, we should leave with better knowledge about clarification regarding common myths and with the right facts, which would help in decision-making and management of patients with back pain per se. Would want to make a humble request. Of course, we encourage questions. We want active participation of all the participants, and to make sure that we are helping you as best as we can, we have a chat box to source your questions. The queries shall be answered after the completion of the panel discussion, which would be for a 30-minute duration. So I would once again welcome Professor Anupam Sibal, the president of GAPIO, the president and Group Medical Director of Apollo Hospitals Group, Senior Consultant Pediatric Gastroenterologist and Hepatologist, Indraprastha Apollo Hospitals, New Delhi, and the past Executive Council of the International Pediatric Transplant Association, the Asian Pan-Pacific Association of Pediatric Gastroenterology, Hepatology and Nutrition, and the Commonwealth Association of Pediatric Gastroenterology and Nutrition. Professor Sibal is the author of the national bestseller, Is Your Child Ready to Face the World? May I request Professor Anupam Sibal to say a few words inaugurating this first GAPIO ASSI webinar initiative.
Good evening, friends. Good evening to friends in Asia and India particularly. Good morning to colleagues in the US and Canada. Good afternoon to colleagues in Europe. And it's past bedtime at 11:30 p.m. I can see Dr. Anju has joined in from Sydney. So we actually have a global audience, and really delighted that colleagues in ASSI chose to partner with us. A big thank you to Dr. Chabra for his leadership, and of course one has always admired the work that he's done at ISI, and thank you so much for bringing us together. My warm regards to Dr. Shankaracharya, President of ASSI, Dr. Ajoy Shetty, Dr. Karthik Kailash, of course, my dear friend and colleague, Dr. Tyagi, Dr. Basu, Dr. Javeri, and Dr. Chehel. GAPIO aims to bring together 1.4 million physicians of Indian origin across the globe on one platform. And there are actually 14 lakh doctors of Indian origin in the world. GAPIO now has members from 54 countries. And from time to time, we come together, discuss important issues that have an impact on how we practice medicine. Of course, we have 15 programs that we have currently running from training young DNB trainees through a mentorship program to many position papers. And we continue to partner with like-minded organizations such as yourselves. We are so happy that this is the start. And I'm sure that we'll be able to have several of these programs in the months to come. And of course, the topic I think that has been chosen by SSI is just so relevant. Back pain. Who hasn't had back pain? You know, I checked on PubMed Central. There are like 328,900 peer-reviewed papers if you type back pain. So that is the kind of data that we have to, go through to kind of look at how important this problem is, and what are the strategies, and what works today, and perhaps what works today might not work tomorrow. Clearly, what worked yesterday doesn't work today. And there's just so many myths. When to see a specialist, should you have surgery or not, case selection, what type of surgery, and then of course with back pain, there's just so much in terms of the mind of the lay public about acupressure and acupuncture and alternative therapy and what kind of painkillers to have. So I think really want to compliment ASSI for choosing a topic that is really important. And I'm sure that the deliberations today will leave everyone wiser, and we look forward to the next session. Thank you so much for partnering with us. Over to you, Dr. Chhabra.
Thank you, Professor Anupam Sibal. As you have very rightly said, back pain is the other pandemic which has been spreading across the globe, and the COVID pandemic has increased the incidence also because of sedentary lifestyles and bad postures per se. So with that, we move forward. We have Professor Shankaracharya, who is the president of the Association of Spine Surgeons of India, the immediate past president of Delhi Spine Society, chairman and senior consultant, Department of Spine Surgery, and the head of Department of Physical Medicine and Rehabilitation, member of the Board of Management, Sir Gangaram Hospital, New Delhi. He has a large number of publications in national and international index journals. Could I request Dr. Shankaracharya to say a few words highlighting this collaboration and how relevant this topic and the other topics to follow would be in the interest of physicians across the globe?
Thank you, Dr. Chhabra, for first of all congratulating you for becoming the honorary fellow of the GAPIO. I thank Dr. Anupam Sibal for having invited us, and I thank Chhabra for having created this collaboration. And I'm really delighted for this excellent start of this session with the topic of back pain myths to be busted. It's a great opportunity, and I didn't know till today that we had such a big organization of 15 lakh physicians and surgeons across the globe or across 54 countries. So that's fantastic. And it's a great platform to be associated with. And I hope Chhabra and others in future would be able to bring ASSI closer to this international organization. And there are so many myths about back pain that it is unending, and everybody is an expert on back pain actually in India, from relatives, friends, chiropractor, Baba therapy, homeotherapy, clay therapy, aromatherapy. Anybody you go to, acupuncture, acupressure, anybody you go to can treat back pain. And so all these myths needs to be busted. And we have one of the most esteemed faculties, Dr. Ajay Shetty and Dr. Karthik Kailash, both who are very closely associated with all of us in the last 20-25 years in the ASSI. ASSI is a small family knit group, and it is a great opportunity for us to learn from people across the world and every such interaction is a learning for us. With these words, I thank Dr. Sibbal and Dr. Chabra and other members of the GAPIO. And on behalf of ASSI, I thank you all for this opportunity. Thank you.
Thank you, Professor Shankaracharya, for those kind words. You have been leading the Association of Spine Surgeons of India and taking it forward with initiatives like these, where we can help reach out people across the globe in order to increase awareness about spinal ailments and its management. So moving forward, I have the pleasure of also introducing the chairperson for the session, a colleague of ours, Dr. Sudhir Kumar Tyagi, Senior Consultant and Advisor, Department of Neurosurgery, Head of Doctorate of Neurosurgery Program by National Board at Apollo Hospital, New Delhi. He did his MS General Surgery from KGMC, Lucknow, and MCH Neurosurgery from AIIMS, New Delhi. He specialized in training of skull-based surgery in Slovenia and functional stereotactic surgery in Sydney, Australia. He has special interest in minimally invasive spine surgery and spinal instrumentation, including craniovertebral junction, and has performed more than 10,000 brain and spine surgeries per se. So may I request Dr. Sudhir Kumar Tyagi to now take over the proceedings of the session and also introduce the panelists of the session. Over to you, Dr. Sudhir Kumar Tyagi.
Thank you, Dr. Chabra. This topic, the myths about and facts about the back pain, is really interesting. And the most important thing I feel is the best thing is when not to operate should be the awareness of any neurosurgeon or the orthopedic surgeon or a spine surgeon. And for that, it is very important to create the confidence in the patients, because the patient who come to the surgeon, they already feel that he's going to get operated. Rather, it is all the way different, all the opposite. The surgeon takes full confidence, control of the disease, and tells him that this is the patient who doesn't need the surgery, and this is the patient who doesn't need surgery. So this is very important to break these myths and tell the facts about the spine surgery and the back pain, the patient who needs surgery, who don't need the surgery. I have privilege to introduce our esteemed speakers, a panelist. The one is Dr. Ajay Prasad Shetty. He is an orthopedic surgeon and senior consultant at Ganga Medical Center and Hospitals Private Limited, Coimbatore, India. Dr. Ajay has undergone the spine training and fellowships at Queen's Elizabeth Hospital, Australia, and is a past secretary of ASSI and board member of the Asia Pacific Spine Society and ISA. Dr. Ajay is an editorial board member of the International Surgery Journal, Aesthetic Surgery Journal, and BMC Musculoskeletal Journal. I welcome Dr. Ajay Prasad Shetty and introduce Dr. Karthik Kailash as well. Dr. Karthik Kailash is an orthopedist and specialist in minimal invasive spine surgery and endoscopic spine surgery, having an experience of more than 31 years. Dr. Karthik is currently working as professor and head of spine surgery at Sri Ramchandra Medical Center at Chennai. He is president of Chennai Ortho Spine Society, as well as adjunct faculty and visiting professor of IIT Madras, and special interest on engineering design and development of medical devices. Dr. Karthik has a special interest in deformity correction surgeries and core founding members of the MIS Society in India. He has published more than 35 papers and given numerous presentations in India and abroad. Dr. Karthik has been conferred the Best Doctor Award by MGR University in Tamil Nadu. Apart from being a reputed doctor, he has played tennis for India in World University Games and currently representing India in the World Masters Tennis Championships. Welcome, Dr. Karthik. So both the panelists are here, I think.
Yeah, both panelists are here, and we will start, with your permission, the proceedings of the panel discussion, which we'll have for half an hour, and then take any questions which may be there. Both Dr. Tandon and Dr. Shankaracharya pointed out that there are a large number of myths prevailing about back pain, and hence we we'll be able to cover only a part of them in this session. We are aware that back pain is prevalent in large numbers across the globe. The figures here from US are evident in this regard, both with regard to the number of people suffering from back pain. They say 1 in 8 would suffer from 8 out of 10 would suffer from a significant episode of back pain at some point of time. The figures here talk about chronic back pain, and the annual US cost for treatment and lost wages of up to $253 billion US. And if it is something like that, you know how in US they would be focusing attention in this regard. So 52 million healthcare visits for low back pain in the US alone in a year, and 9% of all hospital and emergency department visits were with a diagnosis of back or neck pain. And the cost to the hospital to treat back pain was $150.4 billion in that particular year. 291 million lost work days due to back and neck pain. In fact, it is responsible for the highest number of man hours lost in the industry. Despite its vast prevalence and socioeconomic consequences, the knowledge about back pain management is still lacking, and there is a much in wanting in this regard. And the most important factor for lack of knowledge was education, and that's what we are attempting to do today under this initiative per se. We will have a series of questions which I'll throw across to the panelists one after the other, and we'll move forward quickly in this regard. The first one will be directed to Dr. Karthik Kailash. Dr. Karthik, they say if you have back pain, advice should always include bed rest. Is this a fact or a myth? If it is a myth, what is the fact?
Yeah, at the outset, thank you, Dr. Chabra, for the wonderful initiative, and thank you, ASI and GAPIO for having us over. So without wasting time, let's go on to bed rest for back pain. It's a myth. Bed rest is definitely recommended when you have an acute spasm, because at that point of time, you definitely want to injure the rest the injured back. You don't want to provocate the spasm by doing some extra activity, and therefore, at this point of time, you advocate rest. And this rest is usually just indicated for a few days, maybe 3 days or 4 days at the most, and not as is what conventionally written for 3 weeks of bed rest, which is usually recommended in a lot of other places.
Thank you. There is enough evidence in this regard, also from the Cochrane review, that for people with acute low back pain, advice to rest in bed is less effective than advice to stay active. Of course, as Dr. Karthik Kailash said, you may need to be in the bed, but then it shouldn't exceed 48 hours duration or a day or two more. As per the literature. Otherwise, there are chances of the pain becoming chronic. So my next question is to Dr. Ajoy Shetty. There is always a local cause for back pain, they say. Is it a fact or myth? If myth, what is the fact?
Thank you, sir. Thank you, sir, for having me, and my special gratitude to ASSI and GAPIO for having me here. Regarding the local cause for low back pain, when you look at low back pain, the causes could be either a spinal cause, an extra spinal cause. And in majority of these patients, if you see, we may not be able to find a cause like a disc prolapse or a instability or an infection or a tumor. Majority of these patients with back pain can have a pain which is arising either from the musculotendinous structures. We may not be able to localize it exactly, and we specifically treat it by conservative measures, the most of them, and only when it doesn't subside, we ask for a higher investigation. Thank you, sir.
Thank you, Ajoy. As mentioned by you, there can be non-spinal causes also for back pain, and including psychosomatic factors which tend to compound back pain, because back pain tends to increase the stress, which in turn lowers the threshold to withstand pain. And there can be a number of visceral and other causes for back pain, and we should be aware about all of these so that we diagnose back pain properly. So my next question again is to Dr. Karthik Kailash. Radiographs or imaging like MRI, etc., are always needed and definitely establish the cause of pain. as well as the need for surgery. Is this a fact or a myth, Dr. Karthik Kailash?
Yeah, let's break it down into the inciting cause of the pain. So depending on how it is on the age-wise, then appropriately we have to evaluate the patient clinically and then look into it. Most often not conventionally, we look at it and say that if the pain is persisting for more than a week in an adult, then we look at doing at least a baseline X-ray after a week of just basic physiotherapy, medication, rest, etc. If the radiographs are normal, then we continue with the rest. We continue with the conservative management for a period of 2 weeks, or at least up to about 3 weeks. And if it's resistant at that point of time, then we look at doing an MRI. In the interim period, if we do notice that there is a worsening of problem or an onset of a neurological problem or something else which is adverse happening around, then we definitely look at doing an MRI at that point of time and taking it forward.
Thank you, Dr.
Thank
Karthik Kailash. Yeah, did you want to add something, Dr. Karthik?
No, thank you very much.
So there are a large number of people who don't have any symptoms and may show changes on radiology. So the dictum is don't treat a radiological investigation, treat the symptoms and the evaluation unless there's something like infection or neoplasm, which is not so very often and which you can suspect with the symptoms per se also. And most people who experience back pain do not need surgery, even if they show structural damage on imaging. So radiology doesn't guide the need for surgery. It's the symptoms and the signs which are more important. So that brings me to the next question to Dr. Ajoy Prasad Shetty. What then are the definite indications for an MRI? Dr. Karthik has mentioned some, but what would you want to add, Dr. Ajoy Shetty?
Therefore, whenever we see a patient with a problem, the first thing we have to look at is the fact that is there any red flags? The clinical red flags are very, very important. That is, patients with history of neurological deficit, history of pain which is significantly worse in the night and disturb the sleep, previous history of malignancy, history of weight loss or constitutional symptoms, extremes of age, very young child or a very elderly patient. We have to think of omnious. There could be some other cause apart from a non-specific type of low back pain. These are the situations when you may have to think of MRI. But most common indication would be when a patient who has not responded to conservative treatment over a period of 3 to 4 weeks, and there is a suspicion of some other pathology, we always look for a need for an MRI.
Thank you, Ajoy. So the red flags, as you mentioned, has been clearly documented in literature as the need for getting an MRI or a radiological investigation done. So you may not need to get radiology done in all the patients, as also highlighted by Dr. Karthik Kailash before. So my next question to Dr. Karthik Kailash: a firm bed, mattress or floor is always better. We often get patients who say, I had back pain, so I always sleep on the floor now. I sleep on a hard bed. So is that a fact or the myth, Dr. Karthik Kailash?
The fact is it's a myth, but then myths are always made to be facts by domestic conditions. Oftentimes my wife tells me to sleep on the floor if you have a back pain. You can't disagree with that, can you? But then let's look at this way. You don't need to have a flowing mattress or one of those mattresses with a spring cot, which allows your back to sag heavily. If that were to happen, then it's bad for your back. So the baseline is that you should have a base of the back of the bed which is firm, and you could have any kind of mattress which is supportive on that. I don't think ASSI is supporting any form of mattresses at all. So the bottom line is that we use a firm bed and any kind of mattress. It's not necessary to be on the floor. Thank you.
Thank you, Dr. Karthik Kailash. What you said is also backed by evidence. People differ in their response to back pain in regards to mattress firmness. In some, the pain may increase with a firm mattress. In others, they find it better. So very often we say that you may want to use a mattress as per what you find better by trial and error. So that's also what is there in evidence per se. Ajoy, the statement lumbosacral corset should definitely be used to manage back pain. Is that a fact or a myth?
So definitely it's a myth. When you have a patient with a back pain, we have to look at two things, whether it's an acute or a chronic, whether the patient has got a back pain or a radiculopathy. When you are speaking of pain, be acute back pain, whether there is significant spasm, a LS belt or a lumbosacral belt will help the patient to mobilize. It could be used along with bed rest for a period of 2 to 3 days. In a chronic back pain, definitely a LS belt works against the condition, because the primary aim in chronic back pain is basically to strengthen the musculature, the core muscles of the back, whereas the LS belt will cause limited activity and also decreases the strength of the musculature. Thank you, sir.
Thank you, Ajoy. So the orthosis in the evidence, it is not mandatory to use an orthosis. In my practice, I find many patients where the pain increases by use of an orthosis, some benefit. So I tell them, you go by what suits you best. If it helps you, you may use it. But ultimately, you have to build up the corset within yourself, that is strengthen your muscles. So that is generally the advice that I give to my patients. Karthik, once spinal steroid injections are administered, nothing else except surgery would work. That is the statement which many of our patients give to us when we advise them with regard to going in for a facet block or a sacroiliac joint block or transforaminal epidural steroid. So they are hesitant to go in for it. Is that a fact or a myth?
This is a myth, purely because we use spinal steroid injections as a pain alleviating factor and not as a pathology modifying factor. So therefore, it's usually given in so that you tide over, help the patient to get over the spasm and the pain, and then get them back onto rehabilitation and exercises, which will eventually pave the way for a very successful conservative line of management.
So what you have suggested is also there in literature. In fact, there's a huge literature, and epidural steroids are mentioned in standard textbooks like Campbell or Turek or whatever. So there is huge evidence in this regard. If conservative treatment fails, it is a useful option, and surgery is unlikely to be a cost-effective alternative to transforaminal epidural steroid injections. So that is what has been mentioned in the literature, and there's plenty of evidence for that per se. So Ajoy, many patients say we've been told stay away from surgery. It has poor results and high complication rate. And that's the advice that we have got from a large number of people. Is that a fact or a myth?
I mean, it can work both ways. When we have a patient, I mean, patients perceive the outcome should be as similar to an appendicectomy or a cholecystectomy, where you remove the organ, the symptom doesn't happen. But unfortunately, in a back-related condition, it's a part of a degenerative process. And therefore, there is always nothing like a permanent cure. But having said that, in a patient who has got a clinical symptom which has not responded to conservative measures, has got a exact MRI correlation to that, they do extremely well. In a disc prolapse scenario, 95% of them do extremely well in the long run, which is an extremely successful surgically wise. Whereas if you are operating only for a back pain, then the surgical results are usually much lesser. The indications, we have to be very, very careful. Try all conservative measures before you think of surgical intervention. On the whole, surgery definitely is beneficial when there is a good correlation between the symptomatology and the imaging, and the patient has failed conservative measures. Thank you, sir.
Thank you, Ajoy. So in other words, you have mentioned that when surgery is indicated, the outcomes are far better than continuing or pursuing conservative management, and the adverse effects are far less. So if indicated, surgery has good outcomes, but you can always initiate with conservative treatment unless there are red flags. That is the message which Ajoy wants to give across. Am I right, Ajoy?
Yes, sir.
So, Karthik, any abnormal finding on imaging or MRI like a prolapsed disc or a lumbar canal stenosis is a definite indication for surgery. Many times we get attendants of patients who come with an MRI. Doctor Saab, see this and let us know what surgery will you do. So how would you advise such patients or attendants?
Yeah, as Ajoy has very clearly mentioned the previous testing itself, a very good correlation of your clinical findings, your features, as well as an MRI correlation is very important. So just because you find a prolapsed disc or a lumbar stenosis doesn't indicate that the patient would require a surgery. An appropriate correlation with the patient's clinical findings and his symptomatology with the MRI scans is what is definitely indicated, and one should never ever operate based on an MRI finding alone.
So that's also documented in literature that unless there are red flags, a conservative trial should be the first line of treatment. And many of them would improve just with conservative treatment per se. And if the good trial of a conservative treatment, including injection fails, then surgery would be an option. So that is one indication. Any other indications for surgery, Ajoy?
Whenever a patient comes to us with a neurological deficit, which is significant, that is the anti-gravity muscles are affected like a foot drop, definitely we have to consider surgery. When the neurological deficit is progressive and an urgent or emergency decompression or a surgery should be considered in a patient who has got a bladder bowel involvement. Therefore, a neurological deficit is a definitive indication for surgery. A gross instability, therefore, when you take a dynamic radiograph, there is a significant instability is a definitive indication for surgery. Associated with infection, tumors, that too, with there is associated neurological deficit, they again are indications for surgery. Thank you, sir.
So thank you, Ajoy. As you mentioned about the clear-cut indications for surgery, of course, the red flags and a failure of a good conservative treatment. So the red flags to reinforce would be a progressive neurological deficit, Cauda equina syndrome or bladder and bowel involvement is the only absolute indication for surgery in most spinal ailments, the rest being relative indications. Of course, progressive deformity is another indication. Severe leg pain, claudication pain or numbness not responding to a good conservative treatment. Pathological lesions or a spinal instability have been documented to be some of the causes for some of the indications for going in for a surgery. Now, many times these patients come to us and they come out with things like, Dr. Saab, we've been told that once you have back pain or once you undergo a surgery, you have to take a lot of precautions. You can't bend forwards. You can never get back to a normal lifestyle. You shouldn't lift heavy weights. You can't play sports. You can't do this. You can't do that. So is that a fact or a myth, Dr. Karthik Kailash?
Okay, it's an absolute myth, and this has been the bane of the problem for all spinal surgeons, because people shy away from spinal surgery when there is an absolute indication. Now, most people can get back to a comfortable, normal lifestyle, and I've had many patients, and I'm sure all of us have had the same response where people have gone back to a normal lifestyle, including a very good life with athletic lifestyle and leading everything as normally as before, be it a slip disc or be it a lumbar canal stenosis or infective lesion or whatever which caused the back pain. So I think it's important that physicians do disseminate the information that back surgery is not bad surgery and they can get back to normal lifestyle. Thank you.
Thank you, Dr. Karthik Kailash. Dr. Ajoy Shetty, what are your views in this regard?
I agree with Karthik on this matter. I mean, definitely indicated the benefit that if you look at the risk benefit, the benefits of a surgery for conservative management, especially when you have failed conservative treatment, And we have seen people doing marathon, participating in international level sports. I mean, you would know that Tiger Woods, after a spine surgery, underwent to, I mean, still continue to play. Therefore, actually, surgery is really beneficial whenever it's indicated, and you can get back to near normalcy with certain precautions which you have to maintain over a period of time so that the symptoms do not recur much earlier. Thank you.
But would the same apply also if people respond to a conservative treatment, Dr. Karthik Kailash?
Yes, you get back to normal lifestyle with this thing. I'm an example of that. I had an L2 fracture treated conservatively, and I continue to be active playing tennis fairly well with no cause for complaints.
And not only playing tennis, but also playing international level tennis. Dr. Karthik Kailash is in US playing an international tennis tournament, and he has been shortlisted to be amongst the top few. We wish you all the best, Dr. Karthik Kailash, and hope you bring medals back to India in tennis also. I believe it's a tournament of people who are more than 60 or so.
Thank you, sir.
Yeah, so there is ample evidence in the literature, as both Dr. Karthik Kailash and Dr. Ajay Shetty pointed out, that the best way to live normal life or lower your risk of having another episode is to stay active. And this involves cardiovascular fitness, which could be walking, jogging, swimming, getting back to normal lifestyle. And as Dr. Karthik Kailash and Dr. Ajay Shetty gave examples, people have played international level sports, and not only sports, but even American football after major spine surgery. So back pain is not a limitation. It doesn't mean that you would need to have restrictions within your lifestyle. You can get back to a normal lifestyle, but you need to build up on your back muscles in order to get there. So quick question, Dr. Ajay Shetty and then Dr. Karthik Kailash. What is the most common myth that you face in your day-to-day practice with your patients? Dr. Ajay?
Probably one of the most commonest myth is the fact that you have to take a lot of bed rest. That is one of the most common myth. The second common myth is that the surgery in the back always gives you a poor result. Thirdly, LS beds and actions are very, very useful. And probably I would say these are the common myths which I would see in my day-to-day practice. Dr.
Karthik Kailash?
Yeah, I think the commonest one which I see is prolonged bed rest. 3 weeks of bed rest is what people have been advised, and they've been come back after 3 weeks saying they're stiffer than ever before. The second thing is, which I really find hard, is people putting them on pelvic traction, intermittent pelvic traction or continuous pelvic traction, making them lie in bed for hours together and days together. Which is again a complete myth, because it doesn't do. We know biomechanically that a huge amount of force is required to distract the spine, and a 6 kilogram weight or a 10 kilogram weight is not going to do anything much with that, apart from just keeping him in bed. So this is the two commonest things I come across on an everyday basis.
Yeah, thank you, Dr. Karthik Kailash and Ajay. Ajay, you wanted to say something?
Yeah, I would like to add, like in our practice, if you see people who are active, who are going to their jobs, usually tend to recover much faster. Whereas people who take off and who do not take a long duration of leave, we always find their recovery is not as good, and the chance of long-term recovery is relatively lesser. Therefore, the key is to be active, get to work, and to maintain exercises regularly, which helps in the long run. Thank you, sir.
Yeah, one of the other myths which comes from the other side of the table, in my practice, I see a lot of patients who come to us, and even today I have got people from Nepal who have been advised a surgery. I ask them, what is your problem? He says, I have no problem. So any back pain, any leg pain, nothing. So I had back pain and leg pain once upon a time, but all surgeons see my MRI and tell me you need a surgery immediately. So it's not only amongst the society that there may be what we may say an inappropriate knowledge, but the dictum that you don't need to treat the MRI unless there is something sinister like neoplasm and infection, and those two very often you can manage without surgery. So that the knowledge in this regard needs to be spread widely. So I think the take-home message very clearly that has come out of the deliberations today has been rely on evidence and experience and not on myths. In India, people are very fond of advice, and even the maid who comes at home or the next door panwadi or the auto rickshaw driver all would be very happy to give suggestions and talk about experiences of back pain, but we need to rely more on evidence and experience. So some of the most of these myths have been busted, and the facts remain that prolonged bed rest is not recommended and in fact may be detrimental. At the most of 48 hours of rest, but if you can stay active, and that gives the best results. Understanding the cause of pain is important. The pain may be secondary to non-spinal causes also, and very often sacroiliac joint pain or hip pain or pain due to other visceral causes is confused to be from due to pain from the spine, and which is a good evaluation should always be able to point this out. Investigations are not required for all cases. They should be done on case-to-case basis and correlated clinically. Conservative treatment is generally the first line of treatment, except if there are red flags, and the vast majority would respond to a good conservative trial. Epidural injections may help to alleviate the pain and obviate the need for surgery in a significant percentage. Surgery is safe and has good outcomes. It is possible to get back to a normal life. So this is generally, I believe Ajoy and Karthik would agree that these are the take-home messages. If you have anything else to add, Karthik first and then Ajoy, do add.
Yeah, I think you summed it up beautifully. Apart from that, the only thing which I would like to see and tell right now is there has been an increasing amount of people coming in with psychosomatic disorders with the present day age of stress with COVID and everything together. So one has to be very, very wary about evaluating these patients and then offering them surgery, as there's a lot of underlying stress as well as psychosomatic issues. So treat that, and then I think you will have a very good result in managing your back pain. Thank you, Dr. Chabra.
Yeah, totally agree with you, Dr. Karthik. It's not only with back pain, but any chronic pain. They say if pain lasts more than 3 months, the mind tends to get sensitized, and unless you manage the mind as well, you won't get good relief per se. Dr. Ajoy Shetty, any quick other take-home messages?
No, sir. I would like to add only two things. One is that everybody should understand that back pain, majority of the back pain could be treated by conservative measures, and being active, understanding that it is not a life-threatening condition. Being active, doing exercises on a regular basis helps to lead a normal life with minimal disability.
Thank you, Ajoy. I think with that, we come to end of the panel discussion, though we have the question and answer session, which is still there, and we can see questions in the chat box, and I will request the chairperson, Dr. Sudhir, to kindly moderate the question and answer session. And I would want to thank all the panelists on behalf of Association of Spine Surgeons of India, and of course also on behalf of the collaborative venture for joining the webinar today and being with us today. Would also want to thank the panelists, the chairperson, the president of GAPIO and the president of ASSI, and all participants for joining in the session. Over to you, Dr. Sudhir Tyagi.
Yeah, we have certain questions, like one is from Dr. KJ Chaudhary. This is about the cause of the pain, problem in the iliolumbar ligament.
Can I answer that, Karthik?
Sure.
Yeah.
Yeah.
See, the iliolumbar ligament the iliolumbar fascia, they are very, very important because they do contain pain receptors. Therefore, anybody who has got a pain, if you do stretching exercises, I mean, it stretches basically you are stretching the fascia, the iliolumbar fascia, also the iliolumbar ligament, along with the musculature. The pain relief is significant. Therefore, I would say that stretching is one of the important type of exercises, especially in patients with chronic back pain.
What about the iliolumbar blocks?
See, basically, they are pain management approaches to the management of specific pain. They are in an idea to localize where the pain is coming from. It could be in the form of a neural block. It could be in the form of a fascial block. It could be in the form of a iliolumbar block or the trigger point blocks. They all will help us to identify what could be the potential sources of pain for this patient's particular back pain.
So iliolumbar block along with stretching is the complete treatment.
Yes.
for this. So another question is the role of the oral steroids. Oral
Yeah.
steroids in back pain.
Yeah, can I take that, Joy?
Yeah,
Yes.
sure.
Yes, we do use oral steroids on a timely basis when there is intractable pain. Patients already had conventional muscle relaxants as well as anti-inflammatories and still has significant pain, but and you would like to avoid surgical intervention, so you could use a short course of steroids. I typically use it for a 5 to 7 day period on oral steroids, and I find that there is pretty good relief and with this kind of medication for them.
Can I add? Oral steroids probably is beneficial for a radicular pain much more than a chronic low back pain. That is the first important differentiation, and people has to make it.
I totally agree with that, Joy.
I find the usage is much better with cervical spine as compared to the lumbar spine.
Dr. Samrat Sahu is asking one more question. What is the role of the muscle relaxants in back pain and the radicular pain?
Karthik, will you
Sorry,
answer?
sorry, Dr. Sudhir. could you
What is
just-
the role of muscle relaxants in back pain?
Yes, muscle relaxants play a role in giving relief from spasm. And that's very important because once you have relief from spasm, you can then get them back into the exercise table, rehabilitate them, and then get them back into a normal activity. That's very important to use them.
I would say that whenever
Yeah,
we
yeah,
have a
go ahead.
patient, we should first differentiate whether they are coming with an acute pain or whether they are coming with a chronic pain. That is the most important thing. In a chronic pain patients, most of these analgesics we should try to limit because it can cause side effects which they are taking for a longer duration of time. In acute pain, a muscle relaxants definitely would be helpful, but not in a patient with a chronic back pain.
I agree. I also try to differentiate if the patient has spasm or not and ask them if they have muscle spasm along with back pain. I would add muscle relaxants, but generally otherwise would rely on anti-inflammatories per se.
There's one more question from Dr. Chahal. What is the role of lumbosacral belt if there is a instability there? Maybe not a very severe instability, maybe grade 1, grade 2 instability. What is the role of lumbosacral belt in such cases?
Can I take that?
Yes,
Yeah,
sure.
sure.
Sure. This is going to be a little bit dodgy and controversial. In my view, I do not advocate lumbosacral belt at all, even if it's grade 1 instability, purely for this reason that when you have a belt given, the rectus abdominis and the anterior musculature are completely weakened, and this weakness predisposes to further pain, further instability, and therefore I would not recommend. This is my personal view. I would not recommend using a LS corset or LS belt for chronic conditions. Acute back pain for a few days, yes, tide over the crisis. Please go ahead.
So there is a very interesting question also. There is a young girl who's a sports person. She's having grade 1 listhesis. What should we do? Should we go with the lumbosacral belt and the exercises, or we should go ahead with the surgery because she's a sports person? She has to make a career in this.
Ajoy?
So the first important thing, because she's a 15-year-old girl with a low back pain, and she has got spondylolisthesis. The first important thing we have to differentiate whether she has got a high-grade listhesis or it's just a low-grade listhesis. It's mentioned as a grade 1. If it's a low-grade listhesis, then definitely I would advise rehabilitation and to continue her activity, continue playing sports if she is comfortable doing that. We have to first rule out that she has passed the phase of having a lysis, which has not healed. Is there chances of lysis being healed? But just to differentiate, first differentiate whether it's a high grade or a low grade. If it's low grade, then definitely she can continue her activity to her comfort if she's able to perform to the extent that she can play badminton. That's
Yeah,
my-
Joy, it's been mentioned it's a grade 1 listhesis.
Yeah.
So you advocate that could continue with the sports and activities as the pain allows. So would you differ, Karthik?
No, I entirely agree with that. We differ sports only when there is an acute spasm or when there is acute pain. And once the pain is settled down with the conservative measures, we get them back onto rehabilitation, training, as well as back into competitive sport as such.
So the advice from a sports person, surgeon is very important and advocates that the young girl continues to play sports. With regard to this, as well as the previous question, I would want to point out, Rupinder, that we should specify whether it is a radiological instability or clinical instability as well. Because only today I've seen a patient whom will be operating on Wednesday, who has a radiological instability, which becomes grade 2 listhesis on flexion, but on extension reduces fully, and the patient has no back pain, no clinical signs of instability. So you can have patients with radiological instability, but with no clinical instability, though it is not so very common. But so we should always specify, Dr. Chair, whether the patient has radiological only or clinical instability. Yeah, you wanted to mention something. Please go ahead. Unmute yourself. Dr. Chair, unmute yourself.
Sir, these are group of patients who have this instability catch, then they can't walk. They say they'll put a belt, they'll walk, and they're never interested in a surgery. But if you tell them no belt at all, they are then definitely not ambulatory. Then they are that lose their confidence even to walk around.
So that can be two reasons, Dr. Chair. I always tell them if the belt helps you, use it, right? It may be acting by giving temporary support, but I always tell them that try to build up on your muscles. You have to do general conditioning exercise, maintain a good posture, etc. The other way it may act is like a placebo, right? You know, because they have been told that the belt will help them and that helps them. So whichever way, if it helps, right? So we let them use, but they need to simultaneously build up on their muscles. That's what I generally try to advocate. Dr. Sudhir?
In my opinion, this lumbosacral belt is most of the time is psychological support rather than really doing good. So if somebody is feeling good, he can use it. There's another question by Dr. Rajkumar. What is the role of SSRI or SNRI in chronic back pain patients?
Yeah, Ajoy?
I think I'll leave it to Karthik.
Okay. What is the role of SNRI and
SSRI.
SSRI?
Fluoxetine and pregabalins, like.
I'm not a big fan of using it for chronic back pain because I think there is no significant relevance in using them. But then, just as again, lot of back pain, you have to play with the mind too. So you do go use it on an odd basis for some patients, but on a regular recommendation, I'm not a fan of using this. I don't think that I've used it for a long period of time.
Yeah, they may have a role in fibromyalgia, but there are some studies which suggest that they may have a role in chronic back pain, but I use them mainly for radicular pain or claudication pain and do not use them for back pain regularly. So I agree with both the other panelists.
Dr. Bhalla is asking, what is the role of pain clinic and pain consultants, whether it should be before surgery or after the surgery? They should be involved.
No, it's either way. I mean, the pain physicians and pain clinics could be basically run by anesthetists who are trained in pain management and do intervention methods like blocks and things like that. I mean, it will definitely be beneficial in patients with chronic pain, and it's also useful to identify which is the source of pain. It depends on the expertise of the pain specialist to identify and to treat the condition. I mean, every branch has got its role in healthcare, and therefore this is one branch also has got a specific care in patients with chronic pain management. Thank you.
Karthik, do you differ?
My view is a little bit different in this. And, I think any specialty has to be dealt with, like what Ajay said, in a different manner. I think the key thing to be that whether it's a pain specialist or whether it's a spine surgeon or whatever you call it, he has to be appropriately skilled in that area. So if somebody is dealing with the chronic back pain or acute back pain and he calls the pain specialist, he should have a thorough understanding of the subject itself and not label himself as one and then try and go into that. This is what we find a lot of things happening in our present scenario, where people self-style them as pain specialists and then commercialize treatment protocols rather than doing scientific basis of therapy. So I do agree with Ajoy in that sense. Every branch has got its own his role in the healthcare, and every branch has to be developed by the appropriate specialist with absolute care and training.
So
my
my
experience-
viewpoint here, just a minute, Dr. Sudhir, may I? So my viewpoint is that back pain, especially if it becomes chronic, needs to be treated by a multidisciplinary team and can't be treated by a single clinician per se. Way back in '94, when I was in US, there was the concept of back schools, right? Where it would be a team of individuals, patient education, rehabilitation, evaluation to find out the cause and trigger areas. All of these are equally important. And the role of counselors, the role of pain physician, the role of the rehab team, the role of patient education, everything is very important. And at that time also, what we may be missing, pointing out in the team, is the role of the psychologist, right? Every patient who used to be taken up for surgery would go through a psychosocial evaluation, MMPI score. And if it was beyond a certain level, the surgeon would say it is a red flag. I would not want to go in for a surgery. I would rather want to try conservative means. So I think a multidisciplinary team approach, especially for chronic back pain, is very important and well established in literature.
That's what actually this was my take as well. That it should be working together. The pain consultant, the spine surgeon, the physician. Only then we can treat this problem nicely. So this was actually the take-home message as well. So with this, we come to the end of this beautiful session. I thank Dr. Chhabra, both the presidents, ASSI and JAPIO, and Dr. Anupam Sibbal, IT teams, all the audience and the organizers, Dr. Tandon. So thank you everyone for making it so beautiful and successful. Thank you.
Thank you, Professor Sudhir Tyagi. And I would want to put in a special word of thanks for Dr. A.K. Tandon, who has worked behind the scenes a lot to get this going, this initiative going. Of course, on behalf of our president, Dr. Shankaracharya, I would want to thank also Professor Anupam Sibbal, all the participants, GAPIO in general, and we hope to have a fruitful long-term collaboration and look forward to having you all in the next webinar in the series. And we would also want your views on what you would want to hear in the next ASSI GAPIO webinar. So if you have any special suggestions, please jot them down in the chat box or write to any of us, and we will try to schedule the next webinar accordingly. So look forward to having you again. Thanks everyone on behalf of ASSI and GAPIO. And we hope you found this webinar productive. We thought we would not have a didactic lecture format, but have a panel discussion format and have question and answers, because that we feel engages the audience better. If you would suggest that we deviate again from this format, do let us know. Thank you once again. Thank you, everyone.
Thank you, Dr. Chabra. Thank you very much.
Thank you,
May I also place on record my thanks. I mean, you had really done wonderful. And I thank all the speakers and panelists, Dr. Sudhir Tyagi also, Dr. R.S. Chahal, and a few of our friends who joined from UK, Dr. Balmukand Bhala, and Dr. Anju Agarwal from Australia, Dr. Suroj Kumar, I must mention, from Canada, and Dr. Raj Melamore from Canada again, and few other friends. Thank you very much for joining, and we hope to see you in the next webinar. Thank you very much.
Thank you.